So when we talk about patient safety, why we talk about patient safety? Because the transfusion services comes under Drug and Cosmetic Act. So whatever laws which have been laid down for drugs are similarly laid down for the transfusion services. We are legally bound. We have to take a license to open a blood bank from the government of India, and we have to suffice few norms regarding the quality of the component, regarding the preparation, regarding the manpower what we use. So it is something which is bound by government. And when you're bound by a law or an agency, you have to follow the norms. And if we deviate from that laws, we are penalized for that. So it is important. And when you consider medical legal aspects, if there is something which has happened in the hospital, you are bound to be caught, because it's a general tendency. The courts, the public, the media is somewhat is sympathetic toward the person who has suffered. And I think I don't have to tell you this thing. It has been years where we found that doctors or the medical professional involved are at the receiving end. So errors tend to happen because if people are not working, errors won't happen. If you're working, errors are bound to happen. It is a proof that you're working in a system. So when we talk about the patient safety in terms of transfusion services, it can be where we say it is something which starts from a brain and ends in a vein. When a physician thinks that a patient requires transfusion, a specific type of component, that information is transcribed to the concerned person to get the blood, and that concept of transfusion for betterment of the patient ends up in the vein of the patient. And in between this brain to vein, there is a vein of the donor which is involved. So it can be broadly classified in two chains, where a physician patient relationship is there, and a second chain where a donor patient relationship is there. So if we have a chain of events or a process somewhere, these and not abiding with the SOP, you might be able to falter and end up in a error which might be detrimental for the person who has been transfused. So in coming slides, I'll be talking about what errors we generally face and how this can be prevented. So a bit about how the blood bags have evolved. If you talk about, I've not taken a glass bottle. In 1980s, we 80s, I would say in till late 80s, we used to collect blood in a glass bottle, which cannot be centrifuged, cannot be divided into various components. Then the PVC was came into picture, which gave us the leverage to to do centrifugation, separating the blood into various components. So we have evolved from single bag to triple bags, where we can prepare plasma and store red cell for 35 days, to quadruple bags, which means that we can prepare a plated component and a cryo component, diversion pouches to prevent initial bacterial contamination of the components. And now we have those leucofilters attached to the bags, where leucofiltration. We know that specific category of patients require WBC reduced components, and this can be achieved with a specific type of bag, which is attached to the collection bags. You must have heard, you must be using those leucofilters at the bedside when you're giving transfusion. But doing a leucofiltration at the blood bank level or the lab level has an advantage over the leucofiltration what we do at the patient side. So this is how our testing techniques have evolved. Initially, if anybody you have gone to a blood bank which is in the rural area, they still use slides. Those are glass slides where we make those peripheral blood smears. The initial cross matching and blood grouping were done on these slides, and gradually from slides to tube to gel card, microplate, solid phase, and molecular techniques. I've written future, but now we are able to do those cross match and everything through a molecular technique in the blood bank. And similarly, regarding the testing, which is, I would say, an important part of our services, is to test the donors who are coming for donation for various markers. There are 5 mandatory markers by Government of India, which has to be tested for before transfusion: is hepatitis B, hepatitis C, HIV, syphilis and malaria. Syphilis, you say that it is not that common right now, which is used to be in 80s, but we still consider syphilis a surrogate mark for HIV. A person who is syphilis positive has a probability of getting an HIV infection because of the exposure related to the history. So right now we are using a nucleic acid amplification testing. Initially it was rapid. Right now we use RNA and DNA for testing of these viral markers. So coming to the components available, there are a range of components which are there in our blood bank, starting from a red blood cell, FFP, platelets, cryoprecipitate, random donor platelets, single donor platelets. So, and according to the indication or the, we tend to transfuse these patients. So whenever we consider a blood transfusion, take it as an is a transplant of tissue, because blood is a connective tissue and we are taking a connective tissue from a donor and giving it to a patient. So an example of a transplant, because whatever happens in transplant, GVSD, the same thing happens if we miss out on specific things in blood transfusion. A transfusion with a WBC account where count, it might cause a transfusion associated graft versus host disease in the patient. So it's a transplant kind of scenario. We transfuse with various components to stabilize blood volume when essential. I'm putting up when essential because they're normally not indicated to extend the blood volume of the patient. To improve the tissue oxygenation, where we give red cells, and for adequate hemostasis, transfusion of coagulation factors along with platelets. So it has a number of benefits. We can do complex surgeries. It has improved the concept, improved the outcomes of chemoradiations, transplants, but they comes with a risk. Say everything comes with a star, terms and condition. We can transmit a viral infection, I've already told, bacterial infection, which is very common, and we tend to miss out because when we are transfusing, suppose we transfuse a red cell unit, which has been kept at room temperature for a very long time, poses a risk of bacterial contamination. Similarly, platelets, because platelets are collected and stored at room temperature. So there is a high chance that they will support bacterial growth in them. Similarly, immunological reactions, elimination, non-hemolytic reactions, allergic reactions, anaphylactic reactions, TRALI, then I already told transfusion-associated graft versus host disease, which is because of presence of T lymphocytes in the blood bank. Right. So what exactly now? What happens? And in a blood bank, we find components, not fractions. So there's a difference between a fraction, because fractions are prepared in a factory. We take plasma and we do a plasma fractionation to get albumin, immunoglobulins, various factors. Excuse me. So whereas in a blood components are prepared in a blood bank. For components, there is a separate license. For fractionation, there is a separate license. And plasma fractionation is governed by a industrial license, which is not allocated to a blood bank. So we cannot prepare fractions. Similarly, at times you'll be asking about PCC, that is from prothrombin concentrate complex concentrate. We don't prepare, we purchase it from the outside and give it whenever required. Right now, we don't have the license. Similarly, recombinant factor 7A, recombinant factor 8, these are component concentrates which are there in the hospital. You can get it from Department of Hematology, which is used for hemophilia. So I already told these are the components where we use. Initially, when factor 8 was not there, we tend to use cryoprecipitate for transfusion. A word about fresh blood. Try to understand there's a difference between a fresh blood and a whole blood. Fresh blood is something which it varies with definition. For a I would say an OBG person, consider that to be a 3-day-old blood is a fresh blood, or a neonatologist will say a 7-day-old is a fresh blood. So it varies according to the indication. But anything which is within 7 days, we consider it to be fresh. because of the potassium load. Because as the component is stored and kept in our shelf, the potassium load tend to increase. So I'll be talking about what exactly happened to the potassium levels. We don't give a whole blood from our blood bank, but for exchange transfusions or in specific indication, we reconstitute the blood. That is, we mixed up PRBC and a corresponding or the concerned FFP unit and make a whole blood of a specific hematocrit for exchange transfusion or for transfusion for trauma patients. And why we don't give those concept of fresh blood, which is more associated with whole blood, is that we don't get time for testing, because when we collect a blood, the testing usually takes around 24 hours for the result to come, and the freshness will be lost. Take an example: if I have a whole blood, I collect it from a donor. The donor comes at 26 degrees Celsius, and I collect a whole blood from the donor. We take this blood. There are three different components for me. One is red cell, second is plasma, and third is platelets. So what happens? All three components have a different storage temperature. If I want that unit to be used for PRBC, I have to store it at 2 to 8 degrees Celsius. Then plasma, which contains coagulation factors, that quality of coagulation factors will go down. Similarly, if platelets are stored at 4 degrees Celsius, they'll be wasted. And going to a similar other components, plasma and platelets, storing at room temperature, the bacterial contamination will increase, the coagulation factors will go down. So the concept of component preparation not only lowers the risk, but also optimizes the resources. I was talking about what happens about the potassium level. They say that when we give a PRBC, which is stored more than 7 days, the potassium levels are high. If you see the chart, the normal potassium levels is 3.5 to 5.5 milli equivalent. And on checking potassium on day 35, I have taken a day 35 because whole blood cannot be stored more than 35 days. So a whole blood has around 200 ml of plasma, which will have 27 millimole per liter of potassium, and a packed cell will have 70 millimole. If you see, the values is almost twice the what I'm talking about in terms of whole blood in PRBC. But considering the volume of plasma in the individual units, the total potassium load in a whole blood is 5.4, and for a packed cell it is 3.5. So what happens when we transfuse this back to a 60 kg patient? The effective increase in potassium is 0.54. So the effective increase is more with whole blood in comparison to packed cell. But we have to take care of a few conditions. If there is a premature neonate, or the patient is of cardiac disease or renal failure, even a slight increase in potassium can cause detrimental effect in these patients. So we prefer to give a PRBC of pressure to these patients, but rest the patients who doesn't have a comorbidity or doesn't fall in the category of these patients is given a PRBC which is of older age. I won't say old PRBC, but of older age. Even a patient with anemia given a transfusion from a 42-day old PRBC will not cause any detrimental effect because of potassium if the patient doesn't has any cardiac disease or renal failure. So this is a comparison of whole blood and a PRBC. Why I'm talking about this thing? Because people come from different parts of the country to this place, and they tend to ask about why we don't get whole blood over here. So it's a small comparison between the two. The volume is 350 to 450 for whole blood, whereas for a PRBC it is 200 to 250. The increment is same. When we talk in terms of hemoglobin increment, the increment is same, which is same as per PRBC. Red cell mass is equivalent in both. Platelets won't be there because we separate from packed cell in whole blood. If we store it at a specific temperature, the platelets will be lost, the labile factors will be lost. The plasma citrate is very high, which can cause citrate reactions when we give that much of plasma. The allergic reactions are higher because of this plasma proteins as well as because of the WBCs in the bag. Similarly, FNHTR is common, and risk of transfusion-transmitted infection is high, and it leads to wastage of components because if the patient only requires red cells, we are unnecessarily transfusing plasma and platelets to the patient. And when we look at the scenarios across the world, if we talk about the developed countries, the most common transfusion is for medical reason and for surgical reason. That is 34 and 35%. Whereas in India, it is because of pregnancy. Why? Because here we are trying to treat the nutritional deficiency. The patient is having vitamin B12 deficiency or iron deficiency and having a lower hemoglobin. We tend to improve the hemoglobin without looking at the nutritional deficiency in this patient. So there is a whereas in developed countries the level is the percentage is only 6. Similarly, for children it is 14% and 3% over there. So when we talk about appropriate use of red cells, the most important indication is to tide over the oxygen deficit. We are trying to improve the oxygen carrying capacity of the patient. Here, it is very important to understand when we talk about critical care patients, where there has to be immediate increase in oxygen carrying capacity, then we tend to give a fresher unit. The levels of 2-3 dpg decides how much amount of oxygen can be carried by that red cells. But the moment you transfuse them to the patient, the levels automatically increase. These levels during the storage tend to fall down. So in a critical care patients where you think that patient is gasping and will not be able to, the oxygen requirement is increasing and requires transfusion, we can give a fresher unit. I won't say a fresh unit 3-day, 5-day, 7-day old, but preferably 15-day or 20-day old unit can be given to that critical care patients to improve the oxygen carrying capacity. And we don't have to transfuse for treatment of those nutritional deficiencies and avoid single unit transfusion. We tend to say not to give, but the concept is changing. We can give single unit transfusions if the patient requires. But usually what happens, it is the margin. We don't have to give empirical transfusion. We have to give a evidence base. If the patient requires, then only you give, but not that the level has fallen down to 7, I have to give it. So these are the triggers which is normally being followed all across the globe, that we tend to transfuse, the hemoglobin falls below 7, don't transfuse, the hemoglobin is more than 10, and we have to clinically assess for symptomatic anemia or the oxygen carrying capacity when we are transfusing between the hemoglobin of 7 to 10. And if the patient has a deranged cardiopulmonary reserve, then hemoglobin of less than 10 can be transfused to improve the condition. A few other indicators which are more beneficial in the case of critical care patients, where that can be helpful to assess deciding whether the transfusion has to be taken or not. And normal oxygen extraction is 25%. If it increases about 50 to 60%, then we can transfuse. Similarly, mixed venous oxygen partial pressure, if it is less than 4.3, we can transfuse. Excess base, that is bicarbonate levels are more than 30 milliequivalent per liter, and if the patient requires transfusion, that indicator can be taken as a transfusion. Lactate levels more than 2.5 milliequivalent per liter, and if the oxygen consumption has increased by 10%. These are the few secondary indicators which will help you deciding the clinical condition of the patient, where we can transfuse based on the hemoglobin levels. And in terms of neonate, we have different triggers. We tend to transfuse these patients on higher hemoglobin levels. For a symptomatic anemia, 8 gram per deciliter. For a moderate cardiopulmonary disease, it is 10 gram per deciliter. Severe, it is 13. And for major surgery, the hemoglobin is less than 10, we tend to transfuse. Why? Whenever you are sending a sample for a neonatal transfusion, if the baby is less than 4 months old, we have to send mother's sample along with that. We do AB grouping, RH typing, and we tend to give a PRBC or a reconstituted whole blood, which is 7 days, less than 7 days of collection. And we tend to give RH negative units if mother sample is not there or the patient blood group is not found or cannot be done. And CME seronegative unit is issued to those given a smaller volumes to help the patients for the. So coming to the indication of platelet transfusion, we know that they can be given therapeutically or prophylactic. Therapeutically, when we anticipate that patient might bleed in coming time, or prophylactic to tide over the already bleeding patient who has a lower platelet counts. So the various indication where that they can be given at thrombocytopenia patients, uh, in these malignancies, hyperproliferative disorders, DIC, massive transfusions. What normally what happens whenever there is a massive bleed or a trauma patient, there is acute blood loss, tend to give, because the amount of PRBC and FFP will cause dilution thrombocytopenia in this patient. So we have to give platelets also, along with one important thing, that is calcium, because large amount of plasma is given to these patients, which causes citrate toxicity and leading to chelation. So we have to give calcium along with this massive transfusion. And when we talk about triggers, if the count is less than 1 lakh, neurosurgery or CNS trauma is the indication. For epidural catheterization, we tend to keep the count more than 50,000. And if the count is less than 50,000 and we have to go for lumbar puncture surgery, vaginal delivery, we need to transfuse to keep the count above 50,000. For thrombocytopenia with fever or coagulopathy, the count has to be maintained about 20,000. And if the thrombocytopenia is due to marrow failure, we need to transfuse above, we have to keep the count above 10,000. And when we talk about neutral transfusions, these triggers are somewhat similar. The count has to be kept above 50,000 in any case over significant bleeding. Any invasive procedure, count has to be 50,000. Clinical stability, to make stable patient, keep a count above 20,000. And unstable term infant, 50,000, or unstable preterm infant, we have to keep a count of platelet above 1 lakh. So red cell is done, platelet is done. Now coming to FFP. FFP is used as replacement of clotting factors, not as a volume expander or as a supplement for albumin. We give fresh frozen plasma from our department. We give cryopoor plasma from our department. These two plasma components are being given for replacement of coagulation. So when to transfuse FFP, if there is a prolongation of PT or APT more than 1.5 times the normal, we have to give fresh frozen plasma. If fibrinogen content is less than 1 gram per liter, then we have to give cryoprecipitate. And if the platelet count is less than 50,000, we give platelet to the patient. The dose is 10 to 15 ml per kg for FFP. For cryoprecipitate, it's more of a easy calculation doses, that for a 10 kg patient, 1 unit of cryo and 1 unit of PRBC is sufficient. That is, if the patient is of 60 kg, 6 I would say 10 cryoprecipitate, because it comes down to 1.2. And for a platelet, it will be 6 units of random donor platelets, which can be given as a one complete dose. So by single random donor platelets, it is 5,000 to 10. So it's 10,000. And for fibrinogen, one cryo will increase by 10 milligram per deciliter, and FFP 1 unit increases by 8 to 10%. When we talk about 6 units of FFP, we talk that this much amount of FFP will increase the coagulation factors by 30%. If the patient is able to maintain the clotting factors level at 30%, those patients will supposedly not bleed. So these doses are basically for plasma is maintained at a level so that the patient maintains the clotting factor levels of 30%. This is the switching over. Working in a blood bank, shortage of blood it's a common phenomena for us. So these are the guidelines where you can switch the ABO blood group across different blood groups. When you talk, if you have O group patient, they can be only transfused with O group red cells, whereas FFP can be given of any group depending on the order. That is O, B, A, AB. AB is universal FFP unit, but it's less in number. If AB is not there, B and A can be given. The concept here is that FFP doesn't have any antibodies. So AB group doesn't has anything. It is neutral, can be given to everybody. O has all both NTA and NTB antibodies, so cannot be given to all. It can only be given to a O group patient. For PRBC, I think everybody knows that O, it's not O, it's zero. It doesn't has any antigen. And as a law rule, the person lacking antigen forms an antibody. So O group individual have antibodies, whereas AB has both the antigen, they don't form any antibodies. Similarly, the concept of FFP applies to platelets also. This why it applies to platelet also, because we are giving platelets along with plasma. So this crossing over of blood groups is based on the plasma in the platelet concentrates. Similarly, for A and O can be given. For B and O can be given. AB are universal recipients for red cells, whereas for FFP, only ABFP has to be given. And for PRBC, we can give, for platelet, we can give. Reason being that the volumes are low in a red RDP. If the patient requires platelet transfusion to tide over thrombocytopenia, a different group, platelet concentrate can be given. Now, the second thing which is important is the switching over of RH. RH is proprietary of red cell. Only red cells can be RH positive and negative. It doesn't imply on plasma unit or a platelet concentrate unit. So an RH negative can be only given RH positive in very specific condition. We don't transfuse to female till the age childbearing age, that is 45 years of age, or we tend to avoid the patients who females with RH positive transfusion. RH positive can be given to trauma patients or male patients when the RH negative unit is not there. For FFP, no NTD prophylaxis is given. We can give any RH positive negative donor FFP to the patient. For platelet concentrates, there is a concept that 1300 microgram of NTD gives protection against 7 units of single donor. That is what we call apheresis platelets. A dose of NTD can give protection for these amount of platelet units. Similarly, for this can give protection to 30 RDPs. 7 SDPs and 30 RDPs can be given to an RH negative patients after giving NTD prophylaxis. But I tell you that is not commonly practiced. Reason being the collection efficiencies of our equipments and preparation techniques. We check the RBC contamination. If the RBC contamination is high, we don't give the unit to the patient. That is a platelet concentrate which has RBC contamination. We tend to avoid. So in routine practices, we are not giving NTD prophylaxis for the patient until unless the patient has to be transfused and there is more of RBC in the concentrates. So this was all about the components which we have in our blood bank. And now coming to the error zones, I've already told that it's a transfusion chain where it starts from brain to vein, and another vein of a donor is in between. So when I said that if we are working, you bound to do errors. If you're not working, you will not do errors. So based on the way of working, everything, we have found out few zones where error can be identified. And there are 3 main areas in this transfusion chain where there is a possibility that will find the errors to be happening. One is when the sample is collected and sent to the blood bank. Second is when the transfusion is carried out. That is number 3. And third is when we are deciding for the transfusion. So this was a study which was done, and they found out that 39% of the errors which happens is during ordering. 12%, what you heard, you're not able to transcribe on that. You heard somebody else's and you're not able to write down them. Then 11% is during the preparation which happens at the blood bank, and 38% are during the transfusion or the administration of those components at the bedside. So what we did based on this slide, we tried to assess our practices. and we found that 83% errors which happened were happened in the blood bank, and 17% errors happened in the patient. See, we are checking us also along with the practices which are happening in the blood bank. And we found that near miss events were 34% in the blood bank, whereas uh, at the bedside it was 15%. When we talk about near miss event, no harm event, or misadventure, the near miss is that before the error could happen, it was detected. So event didn't happen. For a no harm, the event had happened. That is, suppose take is a patient is of A group, and wrongly O group unit was transfused, and there was no harm because A patient can be given an O group transfusion. So there will be no harm in that patient. So that was a no harm event. And then third is misadventure. When we did the error, there was adverse event happening at the outcome. So we found that errors are happening at both the ends, at the blood bank end also, as well as at the bedside. So why I'm talking about those errors? Because if we are not aware about those errors or this exotic complication of transfusion, we tend to miss out on the things. And what we have reported is only the tip of iceberg. A number of things which are happening under them. So a reporting system has to be essential, which will help us to reduce down these errors. And now the most important part of the presentation is that why we have been telling about transfusion safety is to identify a transfusion reaction. Why? Because missing out on the transfusion reaction might be detrimental for the patient. The patient might lose his or her life if we miss out on the transfusion reactions. And it can happen because of missed transfusions. It can happen because of a bad component. It can happen because of bacterial contamination components, or number of things which are there in the component or the blood bag which is being given to the patients. So third part, which is most important, is identification of adverse events. So the concept of adverse event or transfusion reaction is divided into 4 parts. First, foremost thing is knowing. If I don't, your eye sees what your mind knows or a brain knows. If I don't know that this is a reaction, I will not be able to say. So we should be aware that giving a red cell transfusion or a platelet or plasma transfusion will cause an adverse event. So we need to know, then only we'll be able to recognize. Once we recognize that event, we need to evaluate why this has happened. And if this has happened, we have to manage, treat the patient, and report to the blood bank for the reason to find out why this has happened. So we can divide the reactions into 2 major blocks. One is immediate reaction and second is delayed reaction. During the bedside transfusion, it is more important that we focus on immediate reactions. It can be immunological, that is hemolytic transfusion reactions, non-hemolytic, allergic reactions, TRALI, and a non-hematological, which is bacterial contamination. Bacterial contamination is very common in terms of platelets because they are stored at room temperature and we send to the pods. They're kept on the tabletop, takes around 2 hours or 3 hours before the transfusion is initiated. And in the meantime, the bacterial growth is there and might cause a septic reaction in the patient and circulatory overload. For a delayed reactions, it can be hemolytic or a transfusion associated graft versus host disease. I think everybody might be knowing what happens in a graft versus host disease. When you give a graft to the host for a transplant, the graft poses an immunological reaction against the host cells. So same thing happens over here. When we give a red cell transfusion or a platelet transfusion, and if we have those uh, lymphocytes inside the red cells, those lymphocytes can cause a immunological reaction on the patients in 2 specific conditions. One is if a first degree relative is giving transfusion or the same unit has been given to the patient, because they'll be sharing the haplotype, and if the patient is not able to identify that, it's more of immunological tolerance is there and clearance, which I think gradually we must have read in your subjects. The same concepts work in this. And in second is the immunocompromised patient. So PAGVSD in a first degree relative transfusions and immunologically compromised patients, it happens. That's why to prevent that, we give irradiation to the blood component specifically for platelets for transfusion, which is done with exchange transfusion or transfusion which is given to neonates, newborns, or transplant patients. A non-immunological delay can be RN overload or disease transmission, that is transmission of HIV, B, C, and others. So just to identify easily, we have divided into now 4 basic main symptoms: fever, rash, shock, and dyspnea. If we have fever, uh, the possibility of FNHT or hemolytic transfusion septic and Trali is there. And if we have rash, the possibility of these reactions. Similarly for shock and dyspnea, we can check which kind of reaction probability is there. We know that if there is a rash, then the possibility of having a Trali is not. We can rule out Trali, that patient will not be having Trali. This is how it works, this slate. So we have categorized this thing as in based on the symptoms. What are the symptoms which can be identified during a transfusion reaction? So whenever there's a reaction, it is it is divided based on the case definition criteria, severity grade, and imputability. Imputability means that establishing a relationship with the transfusion reaction. So whenever a transfusion reaction happens, this is the information which is being asked from the wards whenever you are sending a sample for transfusion workup, diagnosis, and because I've told what exactly are the importance of individual things. History of transfusion, type of component which has been given, or the diagnosis, history of pregnancy or transfusion, or any medication which was given along with the transfusion. And each of them has its specific role in identifying a transfusion reaction. I won't be going into detail. I'll be telling there is a book. I'll share the link where it is. You can download that book from the SDBJ internet to go through this all. Then the clinical information which is required is from the ward side is whether PRBC was cold or warm before transfusion, use of warmer or infuser, or the size of needle, whether IV line was used for red cell or it was shared with another thing, any other drug, and the vitals of the patient pre and post transfusion. Sample which has to be sent during a transfusion reaction is EET sample, clotted sample for various tests which has to be carried out. And usually we don't ask for a urine sample, but just to check out whether the patient is having hematuria or hemoglobinuria, you can share the sample of urine sample to the blood bank for ruling out hematuria versus hemoglobin. And these are the investigation which has to be sent: a CBC, plasma urine of sample, haptoglobin, LDH, urea, creatinine, a coagulation profile to rule out the IC, and cultures for ruling out septic reactions. So this is the manual which is there on the SDBJ internet, and which has most of the things which have been told about here, and this is how we can raise a equation for transfusion, and the process how a blood bank works. So this is my journey from student to, I would say, not as a teacher but as a presenter. And it used to happen in mini auditorium, and right now during a Zoom meeting or an online meeting, you can see nobody watches you, but we have slept in front of our speakers. Thank you very much.